Okay, Ernest, we are officially live,
Okay.
and I'm going to have you introduce yourself,
hmm
and we are going to jump into this like hot topic of
Okay.
post-pandemic nursing. But as you mentioned to me a little bit earlier, you were president at the ANA
hmm
during COVID.
hmm
So you have an incredible wealth of information to share with us.
hmm
So I'm going to go ahead and let you kick it off with a little bit of intro about you and nursing and how you got here, and then we'll jump into the meat of it.
Okay, absolutely. Well, first of all, thanks for having me. I am Dr. Ernest Grant and currently serving as the Vice Dean for Diversity, Equity, Inclusion, and Belonging at the Duke University School of Nursing. I started my nursing career a long time ago in the mid 70s, and actually had no idea about going into nursing. I actually wanted, usually I tell people my ambition in life at that time was to be an anesthesiologist and drive a lime green 1968 Mercury Cougar. So I think when your audience finishes listening to this podcast, they will go and look up that car and they will see that it was, and I think still is, the bomb. And I still want one of those cars. But it was a high school guidance counselor who suggested. I came from a very poor family, the youngest of 7 kids in the rural mountains of North Carolina. And it was my high school guidance counselor who suggested that maybe I try nursing and that I could become a certified registered nurse anesthetist. And then if I still wanted to go on to medical school, I could work my way through medical school by working as a nurse anesthetist. It sounded pretty good, so I started in nursing school as I was in a LPN program, and about 3 months into that program, I totally forgot about medical school, realized that nursing was my calling. However, the role of the LPN at that time, we're talking the mid 70s, so you get some idea of how very old I am.
You're not
The
old. You're
No,
just
no.
you're just experienced.
Yes, just experience. Yes, seasoned, I would say. But the role of the LPN at that time was very limited, and I wanted to be able to do more for my patients. And so I realized that in order to do that, I needed to have a baccalaureate degree. So I started working on my baccalaureate degree, and then subsequently master's and PhD. I spent 36 and a half years working in burns and critical care at the burn center at UNC Hospitals. Loved every minute of it, and would go back to doing that in a heartbeat. But I also got very active within the nursing profession for several reasons. One, I wanted to try to encourage more men and ethnic minorities to enter the profession. I wanted the public to understand who we were as nurses and what we bring to the table, and also encourage nurses to advocate for the profession. So those are pretty much my 3 goals as I began my active career, being active within the profession as well. So having served as the president of the North Carolina Nurses Association, I also started working at the national level. And finally, on June 18th, 2018, I broke the glass ceiling and became the first male president elected to the office of president of the American Nurses Association. At that time, it was 122 years old. So it only took
It only took
122 years.
122
Yeah,
years.
yeah. And the third African American to serve as president. So, and of course, a few months later, a little bug came along called COVID, and that sort of changed the trajectory a little bit as well of the goals and objectives that I had. But we weathered that and learned quite a lot, and here I am.
Talk about being hazed into a profession. I mean,
Mhm.
you really COVID like hazed you into that
Yes, it did.
position.
Yes, it did. I think one of the challenging things about COVID, well, actually, there were plenty, but The first one was obviously caring for my fellow nurse colleagues and recognizing their needs. At that level, when you're president of a national organization, particularly one like the ANA, you meet with a lot of people in all different realms and positions. And so hearing from nurses across the country what was going on, meeting with members of Congress to tell them that, one, the stockpile that was there was not working as well as they had planned because the supplies were not rotated in the way that they were supposed to have been rotated. So the mask that they would send out to members of the healthcare team to begin to use, they had dry rotted. There was a lot of counterfeit masks coming into the country that did not meet NIOSH standards, and other things that were going on. So,
what does that mean, counterfeit mask? I haven't heard of that.
Counterfeit.
Oh,
in other
counterfeit.
Words,
I thought you said cattlefitt, and I was like,
no.
cattlefitt? I was
Sorry.
like, is this for like cows? No, although it wouldn't have surprised me.
Yeah, it still wouldn't have worked. But
all the nurses listening are like, yeah, it felt like I was being.
That's my accent there. But it was, but yes, letting them know that there were a lot of counterfeit masks being shipped into the country, which again would further expose members of the healthcare team because they did not meet NIOSH standards. So,
right.
So they might as well just had not have any masks on at all during that time. And also just educating the public. Once the vaccines were approved, and I participated in the clinical trials for the vaccines, and so I wanted to be able to say that they were safe and that I personally had participated in the clinical trials and knew that they were safe. So that lent a little bit of credibility, not only to again my fellow nurse colleagues, but also to the public, and in particularly to people of color who tended to have a little bit of hesitancy regarding trust of the healthcare system. So yeah, that was just part of that, and that's the reason I have all this gray hair. My hair was all black at that time.
It's like being the president of the United
States,
being
the president of the United States, absolutely. So but I tell people this is earned wisdom. So.
Oh, for sure, absolutely.
Yes.
Well, so I think a lot of things that you said were really interesting, right?
Mm-hmm.
So, I mean, one of the things was that I think that like nurses, especially during that time,
mm-hmm.
were very frustrated.
Yes.
So I'm currently I'm in a writing clinic.
Mm-hmm.
Okay, and it's at Cal State University of Los Angeles,
mm-hmm.
and I'm working with a bunch of nurses, and we are all writing about
mm-hmm.
our time
experiences
mm-hmm. during COVID, and it's all going to be read at a theater,
mm-hmm.
and it's so interesting to go around the table and
mm-hmm.
and hear everyone's experiences. There's someone at our table who worked in infectious disease, who's
mm-hmm.
been a nurse for 36 years,
mm-hmm.
And her experiences. And then there was people who were working in public health. There was people who were working at the bedside in critical care. There was a new nurse who literally had just graduated from nursing
mm-hmm.
school and dropped right into
mm-hmm.
an ICU.
Yes.
And you can only imagine, right, how
yes.
bad that would be.
Mm-hmm.
And so just all these different perspectives.
Mm-hmm.
But one of the things that keeps coming up in this writing conference or this writing clinic that I'm in is how things just changed constantly,
mm-hmm.
right?
Mm-hmm.
And everyone who's worked at the bedside has been fit tested,
mm-hmm.
right? We've all done fit testing.
Mm-hmm.
And we know that, a N95 mask is
mm-hmm.
rated for 90 minutes or,
yes.
and that after that, it's not really working.
Mm-hmm.
And so then you've got masks sitting in a paper bag,
mm-hmm.
right, for days.
Mm-hmm.
And you're reusing it.
Mm-hmm.
And the confidence level, right, is just dropping.
Yeah.
And so now you've got all these healthcare workers who are asking themselves, well, all these years I've been told this is how it's done, this is how it works. Now suddenly this is sufficient enough, or I can't bring a mask with me if I get
Mhm.
access to a mask. That was a lot of stuff that I was hearing too, is that some nurses would actually secure some N95 masks, or
Mhm.
that they would get access to them and they'd try to bring them with them. They weren't allowed to have it.
Mhm.
And how how was that for you as the president of the ANA? Were you hearing a lot of, I'm sure you were hearing a
Yeah.
lot of similar
Oh,
concerns.
absolutely. One of the things that I did as president, I had a group of 60 nurses around the country that I spoke to at least once a week. And they were in all areas, critical care, emergency room, community, nursing instructors, and et cetera, and in different areas of the country. And because I wanted to know what was going on in their neck of the woods, because I figured if you're seeing it in Iowa, then chances are we're going to see it on a national level, and we need to be prepared for that. And so, addressing the issue with the N95s and the reuse, yes, of course, we had been, everyone has been taught that, as you said, they're only good for about 90 minutes, and then you discard them. But then working with health officials and those of the COVID task force, and looking at some of the studies that were being done, and looking at the size of the virus, and et cetera, and the way that some of the masks were re-sterilized, or being able to be re-sterilized, and being tested again for their efficacy. That was some information I was able to pass on to nurses to help boost their confidence, in that. But yes, rightly so. Nurses at the beginning, when hearing that, what you've been taught, and then suddenly, the mere fact that suddenly, well, this has changed, and that was almost something like on a daily basis. You were seeing or hearing, things change, and so it did sort of cause the credibility factor to be brought into question. But I think, though, the one constant, hopefully, that I was able to provide, being the leader of the nation's, well, at that time, 4.8 million registered nurses, was to say, no, we're working closely with, officials at the CDC, officials at the COVID task force, and et cetera. And yes, the more we learn about this virus every day, then yes, that does cause changes in the way that we approach things. But it's a way of being able to educate and explain to nurses that because of what we just discovered, this is what we can do, as opposed to, I think, other individuals who were out on the forefront, and the various task force, they perhaps did not go into a very thorough explanation, and so that left a lot of doubt for some people. But hopefully, I mean, I felt that my being able to really just get down to the nitty gritty and saying, yes, because of what was discovered, or a later or a different approach that was investigated and proven to be effective, this is why we can at this point still continue to reuse those N95s, or again, because of other sterilization methods that were brought about as well, that made them still effective, for second and third use, as opposed to just the 90 minutes and throwing them away. Plus, keep in mind too, there was a significant shortage of those as well. There was, reports of hospitals that would, bid. Sometimes, I know in one case, one hospital bid something like $4 million, to purchase some masks, only to be outbid 10 minutes later by yet another hospital. And again, and some of these were some of those counterfeit masks that I had talked about earlier. So again, notifying members of Congress that you've got to do something to stop these counterfeit masks from coming into the country. Otherwise the situation is going to get much worse. So again, being able to alert them about that was something that was very helpful as well.
Yeah, it was a really odd time of opportunism
Hmm.
where there was all of these bad actors
Hmm.
out
Yes.
there really trying to prey on this need.
Hmm.
And so I'm glad that there was someone like you
Yep.
who was advocating to Congress and talking about that,
Yeah.
because I used to get, it was bizarre, but I used to get WhatsApp messages
Hmm.
all the time
Hmm.
from random people in
Hmm.
other countries,
Hmm.
sending me notifications that I could, you know, I could buy masks from them
Hmm.
for, X number of dollars,
Hmm.
or I could buy them in mass quantities. And there was all these shipping, you
Hmm.
know, and I'm sure that they thought, well, I'll buy them and then I'll go ahead and
Hmm.
I'll upsell them here,
Hmm.
or it was a really weird, very strange time.
Very, absolutely. And of course, on top of that, too, you had people who were um, deniers that, that this was even happening. And, or people who would start other rumors and things that, so it was pretty hard to, and one of the things that, that I would truly stress for people is to, who you could believe, who were some of the trusted sources that you needed to get your information from, as opposed to believing what you perhaps may have read or seen on social media and things of this sort. So that again, it was almost like there was a denial of science or evidence-based science or evidence-based practice that we knew, and that too contributed to a lot of distrust that people had, not only the general public, but also some members of the healthcare team as well. And
Yes.
so by being a trusted source, hopefully you're able to dispel those, um, you know, um, differences that people had or the doubts that people may have had.
Did you ever hear about the town hall that LA County General Hospital was having? Uh,
Yeah.
so this is so interesting, and I would encourage all of our listeners to check this out if you have an opportunity. It's on YouTube, and you can go back to
Mhm.
April of 2020, and they they put on a town hall. They had the largest number, really, of COVID
Mhm.
patients. It was
Mhm.
even of monkeypox, when monkeypox hit the scene.
Mhm.
They Because they were county general, right?
Mhm.
So LACUSC put on a town hall, and they were educating like all 3,000 of their staff
Mhm.
via this town hall. And I learned about this at my writing clinic because there was a couple
Mhm.
of nurses from LACUSC,
Mhm.
and they were talking about how their infectious disease director was on
Mhm.
it, their CMO was on it,
Mhm.
their CEO, and it was fascinating. I haven't had a chance to even go look it up, but
Mhm.
apparently, if you go to YouTube and you look up LA County
Mhm.
USC Town Hall,
Mhm.
they've kept it going. They've
Oh,
actually
good.
kept this town hall going, which is so interesting because
Mhm.
they continue to inform their staff.
Mhm.
And I thought, wow, I wish I had known about that, because I would have gone and visited it. It was an open, public town
Mhm.
hall
Mhm.
that anyone could have joined.
That's
So,
great.
yeah, so I'm sure throughout the nation there was probably other
Mhm.
people, other organizations doing similar things.
Yes.
I think one of the problems, and especially as we kind of start talking a little bit more about post pandemic, right?
Mhm.
Like, there's a lot of trauma that
Mhm.
happened for our nurses. I'm definitely ex- experiencing and
Mhm.
re-experiencing it now through this clinic, this writing clinic that I'm
Mhm.
in, which I really do recommend that nurses, if you're listening to this, I have found so much. It's been very cathartic, very healing
Mhm.
for me to write my stories.
Yes, it is.
Yeah,
If I may,
absolutely.
um, so during COVID, the country shut down. I remember exactly Friday, March 13th. And literally, one of the things we did at ANA was that, obviously closed the office, but by Monday, opened up virtually, had educational resources online for nurses, talking about how to don and doff, gown, mask, gloves, things of the sort, how to take care of an intubated patients if they were going to be, nurses who weren't in the ICU. But a little bit later on, we also began this Pulse of the Nation's Nurses series. And one of the things that came out of that, several things, but the most important one, and I remember it was in May when the first report came out, there was clear evidence that nurses were suffering a lot of mental anxiety. Obviously being asked to work, double and triple overtime, seeing death and dying on levels that you've never seen before, or in hospital wards that normally didn't experience death and dying, and now they are at all levels, and et cetera, is just really just heart wrenching. And so the American Nurses Association, along with the Emergency Nurses Association, the Critical Care Nurses Association, and the Association of Psych Mental Health Nurses, created this well-being initiative. And part of that, one of the things, like you were talking about, the writing that you're participating in, that was one of the things that we encourage nurses to do as well in order to deal with the behavior issues that they were suffering. Also, there was a lot of things that I learned, like, some nurses, there were volunteer counselors, who were willing to listen to nurses' stories, but we found out that nurses were sort of reluctant to do that because if it showed up on their insurance, or it's a possibility that they may lose their license because it would say that you have sought counseling, even though it may not be in relation to what was what was going on. It could have been either something going on in their personal life, like a divorce or whatever. But we automatically just think that, oh, counseling, there's a mental health issue, like if the person, perhaps is, suffering from anxiety or maybe bipolar or something like that, when in actuality it's the stress, or it was the stress of the job and what was going on. Other things as well, that's where we started the, sort of the campaign of telling nurses, put your own mask on first before, helping others. In other words, take care of yourself. Make sure you're getting enough rest. Make sure that you are eating properly. Look out for those little signs of, am I, turning to alcohol too much? Or, if I'm a smoker, am I smoking too much? Or do I find that my temper is very short? I get very short with my colleagues, and et cetera. All these are things that nurses needed to pick up on and obviously do something about. And of course, that still goes on to this very day, because COVID is still active. It's not, obviously, and thank God, it's not as prominent as it once was, but, people still, do come down with a COVID infection. But it is, it was just the country, or the globe actually, had never experienced anything like this. I mean, obviously they attributed the Spanish flu as something close to this, that happened 100 years before as well. And I was able to go back and look at the records of who was president at ANA at that time and what she did. And it turns out she was an old Army nurse and had sort of a playbook. And, we sort of followed that playbook as well. But nothing to, when you look at modernity and how things has changed from 100 years ago, we need to be able to adapt. And of course, this leads us to where we are post-COVID. What's going on? Nurses are still having, those behavioral issues. Nurses are coming under attack. As a result of this, the whole country sort of seems to be very on a short fuse. When you hear that nurses are being abused by patients, by family members, by their colleagues, that nurses are wanting to leave the bedside at a much faster pace than they did in the past, or older nurses like myself, are choosing to retire early all that's contributing to a workforce shortage and other workforce issues that we still need to address. And even though we may think that, oh, well, we accelerated telehealth and telemedicine, yeah, that's good, but it still is not as good as being able to do that one-on-one, do that hands-on with the individual. In most cases with telehealth and telemedicine, you're just seeing the person from the neck up. You're not really able to do, the physical, hands-on things that could also help you when it comes to, diagnosing or assisting with diagnosing a particular illness or something that you may see. So yes, it does help as far as with increasing access to care, but is it giving you good quality care that that you really need to have if you were
Yeah, I
in the
think it's a
room with that
supplement.
person?
Yeah, right.
Yeah.
It's important that we take these opportunities to integrate new technologies
Hmm.
and use them where they're appropriate, right?
Absolutely.
Not
Hmm.
to supplement. You don't want to supplement everything. You don't want to replace everything, right?
Absolutely.
It's you have to use it where it's going to be well suited,
Right.
and uh, and then frees people up. I think
Hmm.
that that's the idea really, is that we want to make
Yeah.
sure that we're freeing up our healthcare workers, our
Hmm.
clinicians,
Hmm.
to be able to do what they signed up to do
Absolutely. This
that
needs to be,
job.
well, it needs to be viewed as a tool,
Yeah.
and not as a replacement,
Yep.
but as a tool to to help us to achieve what we need to achieve as far as with providing better care for the individual. And it's better than nothing. When you consider the number of hospitals that are closing, that we're hearing now, and which may create quite a challenge when we think about access to care, particularly in the rural parts of the country. Somebody that maybe had the ability to, maybe there was a hospital within a 15 to 30-minute ride from their home. Now they may have to ride over an hour and a half to 2 hours. So yeah, using telehealth may work in that particular situation. But the main thing is we still need to be able to get um, you know, physical, healthcare providers within the community, as well
Yep.
as, get rid of, or increase, or well, I should say, get rid of the drugstore deserts that don't exist. Putting drugstores and grocery stores in those rural communities as well,
Right.
and partnering with people, with leaders in the community, so that we can meet the needs of whatever the community may be, so that they're not abandoned, or that we don't see them when it's too late, when something like a 25 or 50 cent a day pill could have prevented an illness, and suddenly we see them having a stroke or something like that that could have been easily prevented had we been able to have more uh, you know more access to care.
Yeah, if we were just able to intervene, this is why I really think the whole nurse practitioner route
Hmm.
is so important. And
Yes.
and providing them with the ability to practice with some level of autonomy
Absolutely.
is so important, because they are the ones that want to get into those areas where there is a lack of access.
Absolutely.
It's the NPs, it's the
Hmm.
PAs. They're
Yeah.
the ones that want to stand up the clinics,
Yep.
and especially in communities that are lacking
Hmm.
access to real care, and especially
Hmm.
preventative care,
Yes.
right? And because ideally there was a time, a long time ago, when when you ended up in a hospital, it was
Hmm.
because you were very, very
Sick.
sick.
Hmm. Hmm.
And the only people who went to hospitals
Hmm.
were people who were very sick and
Hmm.
possibly dying, at risk
Yes.
of dying.
Hmm.
And somehow along the way, that shifted,
Hmm.
and people found themselves going into an emergency room with a cough and a cold,
Hmm.
and they just didn't have access
Yeah.
to preventative care and to
Right.
primary care.
Yeah.
And so I
or
think nurse practitioners are going to be part of that solution.
they,
What are your
they
thoughts
are.
on that?
Oh yeah, absolutely. I mean, even here in my own home state of North Carolina, there are 3 counties in this state, very poor rural counties, but the only health care that is given is provided by nurse practitioners and PAs. And the hospital, the nearest hospital, in some cases is like an 80-mile drive away. So yeah, it is a proven need that those providers do serve a much needed need and a much needed population that our physician colleagues perhaps do not want to do. And that's the thing I really think we need to stress to our physician colleagues is that nurse practitioners and PAs, they do not want to take your job. They want to work with you to provide the care that is so sorely needed. But when, like here in North Carolina, we've been trying to pass a bill that would allow nurse practitioners to have, full practice authority. And this is year 7. And each year, we thought we had it last year, but there's one person in the legislature who happens to be a physician who's holding up the whole thing. But yet, you would think that they would realize that, think of all the hundreds of thousands of people, that could be better served had that bill passed. So we're still trying to get it passed again this year. And I'm sure it's just one example of that all over the country. But when you look at states that have that, and look at and actually the pandemic, getting back to that, was a perfect example or perfect experiment of how successful allowing nurse practitioners and PAs to have full practice authority. Because remember, they implemented, a emergency, care thing, which allowed, NPs and PAs to have full practice authority. And, the biggest fear that a lot of people, always said was, oh, if that happens, there's going to be utter chaos. There's going to be people dying right and left and, this and that, et cetera. It never happens. What better experiment could you ask for? That, they would think that, oh, they're going to be, prescribing, misorders and things of this sort. Not one case did that ever happen. Yes, people were dying, but they were dying because of COVID, not because of, the way that, people were thinking they may have been misdiagnosed or mistreated by an NP or a PA. So we have the data to prove that it works. We just need to get, obviously, as you know, it comes down to a matter of dollars and cents and et cetera, but we need to get payers to begin to really want to reimburse more for what, nurse practitioners and nurses in general bring to the table. That's another one of our big issue is that, nurses, we're counted as a commodity, being put under the room and board. There's something wrong with that.
Yes.
I've long said that we should be able to charge for what we bring to the table, just like our physician colleagues, just like our physical therapist or respiratory therapist or occupational
Yep.
therapist. We go to school just as long, if not longer, than they do. We are a true profession. We have our own body of research, things of this sort, our own standards, our own code of ethics, but yet we are treated as a commodity. And there's something wrong with that picture when
It's very
we're that way.
it's very odd. I spoke with Rebecca Love. I interviewed her.
One of my favorite persons.
One of my favorite people. I always say I've known her for years and years, and she speaks faster than any person I've ever met on the planet. I don't know how her brain,
Yes.
how her mouth keeps up with her brain. But she has so much. She has such a wealth of knowledge around the history
Yes.
of nursing. To what you just said, if anyone's interested, they can go back and listen to the episode Commission for Nurse Reimbursement. We did it here on this podcast with Rebecca, and it's so fascinating. It's still one of our top performing podcasts,
Well,
if you
great,
can believe it.
I can.
Yeah, because nurses want to know that well, why am I a cost to the system? Why am I not a benefit to the system? Why can, if we are a business, right? If healthcare is a business and
Yeah.
that
And
doesn't
it is.
seem to be changing anytime
Yes.
soon, then why would they not want to say, okay, here's the value around having a nurse? You know, here's how much the hospital was able to receive in revenue
Yeah, or save because of
or save.
things that nurses have done, or prevented from happening, and et cetera. Absolutely, we're more than worth our weight in gold. It's just the fact that for some reason, it's just been put into our or out there that no, you work for this amount, and et cetera. And never was that more proven. Nurses were able to prove their worth than during the pandemic. The mere fact that and it's weird because at the first part of the pandemic, the country loved us. You got the applause at night, and great job and everything else. And then somewhere near the end of that, again, there was that change as they began to have a change in whether or not to believe science. And
Well, it
is
got
this working?
politicized, didn't
Yeah,
it?
it got
It got
politicized. Absolutely,
politicized,
it absolutely did.
it was
And
a
as a result of that, nurses began to suffer the physical harm.
yeah.
We've got to change that.
Yeah, as opposed to looking at it as a public health crisis, which is what it was.
Yes.
Yeah, it was politicized, and then there were people on just one side or the other,
Yeah.
and that just added to, I think, more of the moral injury
Mm-hmm.
that so much of these nurses experienced.
Absolutely.
And it's not lost on us that nurses have been experiencing trauma and moral injury and all of this burnout for years and years
Since
and
day one.
years prior.
Yes.
So really, this was just the icing on the cake, right? Like
Yeah,
this
absolutely.
was really just the straw.
True.
Uh, yeah.
But I still would, even though we're painting a sort of a gloomy picture, I still would encourage people to go into the profession. It's the best thing that that I ever made, the best choice. I have never regretted choosing, going. Actually, as I tell people, nursing found me. I didn't find nursing, but I've never regretted, being a nurse. And one of the things that, I've been a nurse, almost 44 years now. And, I can ask, I do ask myself this question at the end of every day, did I make a difference today? And I can truthfully say every day that I can answer yes. Whether I was at the bedside, whether I was, in an administrative position, whether I was, as I am now as a educator, still making a difference in some way or another. Either advocating for the profession, advocating, on behalf of nurses, or advocating for the people that that we serve. And getting that out there. Just having my voice heard and encouraging other people to have their voices heard as well, so that we can continue to make a difference and get people to continue to appreciate who we are and what we bring to the table. Even though, for the past 23 years in a row, we've been voted the most honest profession. Honesty is one thing, but but it's a matter of respected. Being being respected and being paid for what you bring to the table.
Absolutely. Because we've been given more and more responsibility. I've interviewed so many people who have been in the profession for decades, like you, Dr. Grant, and then I've talked to people who have been in the profession only for a few years. But when I talk to the people who have been in this profession for decades, they will say, slowly but surely, I've been given more and more responsibility, right? And even people that I've talked to who have been nurses for 50 years, who will say, there was a time when you couldn't even call it blood, or you weren't allowed to take a blood pressure,
Mm-hmm.
or the physicians were incensed at the
Mm-hmm.
idea of a nurse being able to take blood
Mm-hmm.
pressure.
Mm-hmm.
That's a medical thing. That is
Yeah.
not something that they do.
Mm-hmm.
And now you look at what nurses do,
Mm-hmm.
and the number of times that nurses are the ones,
Mm-hmm.
making recommendations
Mm-hmm.
and catching errors
Mm-hmm.
and all the stuff that we do. And then more and more things are just, the nurse will do it. The nurse will do it. The
Mm-hmm.
nurse will do it. And, but the respect, the pay hasn't
Mm-hmm.
matched the level of expectation and the
Mm-hmm.
level of workload,
Absolutely.
yet the same outcomes are expected,
Mm-hmm.
and the same patient satisfaction is expected.
Mm-hmm.
And I have you watched, Dr. Grant, did you watch The Pit?
No, I haven't yet.
Okay. So I've been told now it came out in January of 2025. It's
Uh-huh.
on Max.
Okay.
And this is not an ad for The Pit. Just in case
Yeah.
anyone's
Yeah.
wondering, they're like, boy, they're getting paid to advertise The Pit? No, we're not. But I was told by all my colleagues,
Mm-hmm.
you got to watch The Pit. You got to watch The Pit. And most of my colleagues being actually
Mm-hmm.
non-clinical over
Yes. Mm-hmm.
at Relies. So finally, last weekend, I binged it. I
Okay.
watched the whole thing. Okay, so every episode is an hour
Mm-hmm.
of a 12-hour shift
Oh, wow.
in the ER in Pittsburgh.
Mm-hmm.
And I can't tell you how realistic this is.
Mm-hmm.
It is, I'm sure it's going to win lots of awards. There was a period of time where I wasn't sure I could watch it. I was like, maybe this is a little too close to home.
Mm-hmm.
I felt a little PTSD kind of
Mhm.
welling up inside of me. But the thing is, it was fascinating because, and I think you'll find it really interesting because they touch on everything.
Mhm.
They touch on violence
Mhm.
in the workplace. They touch on just the dynamics between nurses and doctors, between doctors and doctors, between
Mhm.
interns, med
Mhm.
students,
Mhm.
all of that.
Cool.
They touch on the staffing. They have an administrator who keeps coming down and
Mhm.
talking about patient satisfaction, and the chief in the ER who's saying, "You want patient satisfaction? I need staff.
Even staff, yes.
I need staff. You can't have patient satisfaction without staff."
Mhm.
And I thought, thank God somebody
Yeah,
made
that's
this.
great. It sounds great. It sounds. I definitely will have to watch that.
Yeah, because I think that it's important that the public, because you were talking a little bit about how the public
Mhm.
perceives us,
Mm-hmm.
how hospitals treat
Mhm.
their staff.
Mm-hmm.
All of this is so important. If the public wants to have care in the future,
Yes.
because the next biggest public health crisis is going to be nurses leaving.
Yeah.
That is going to be the next
Mhm.
public health crisis.
Well, it's already happening.
Yeah.
I mean, we know that there's, within the next 5 years, there's going to be a need for at least, upwards of about 1.5 to 2 million registered nurses. We only graduate about, about 250,000 every year, and most of them are not staying at the bedside. You're lucky if they're there for a year, and then again, like I said, people my age who are choosing to retire. The average age of the nurse at the bedside is about 56, 59 years of age. So yeah, that's it. And as hospitals and healthcare expands out into the community, there's still, as they have, either standalone clinics or build satellite hospitals and et cetera, as they try to bring healthcare into the rural communities, you're going to need people to staff those positions. And, so there is still that need. And, one of the things I tell my students, particularly those who are thinking about coming or going to become nurse practitioners, I try to encourage them to become geriatric nurse practitioners because every day for the next 30 years, 10,000 Americans are going to be turning 65, and we're living longer. So we're not, like my grandparents or great grandparents who lived to be like late 60s, early 70s. We're living longer into the 80s, the 90s, and 100s, and we're healthier. We're not bedridden. They're going to walk in with a laptop or whatever else, and just like other patients that we see now, saying, "This is my problem. This is what you're going to prescribe for me," and and
Yep.
then expect to walk out the door and go play
Yep.
around the golf or something. So yeah, there is that increased need, and we definitely need to do something about that to help meet that need.
So if you had to, I'm gonna I'm gonna I'm gonna make you paint a picture.
Hmm.
So let's jump forward 10 years.
Hmm.
What do you foresee happening? What do you see in terms of more community based, like
Hmm.
healthcare? Do you see that being more home healths, more hospitals that have their own home healths? Do you see uh, more clinics, that are run by
Hmm.
NPs? Uh, how do you see AI
Hmm.
coming on the scene? Like, where do you see that filling the gaps?
Hmm.
Uh, what does that look like to you if you had to look
That's
ahead
a,
10 years?
that's a really great question, and I think in 10 years, well, one, I hope that there are more ethnic and minority nurses, that are there, and more men within the profession, and that the profession is more highly regarded than it is now, currently now. I think embracement of innovation and technology that is nurse driven, because nurses, we are agents of change. We find those little workarounds, if you will, that present challenges, and so I see us embracing, like AI, other things like that, to help us be able to work smarter and not harder. But again, use that as a tool for what we still need to do. I still see that there's going to be the need for that hands-on, person-to-person, interaction between the nurse and the patient. So I really don't see that, even as we perhaps embrace more robotics and things like that, I really don't see the replacement of the human being. There's nothing like the human touch, and nothing like the touch of a nurse that we can bring to the bedside as well. So I still think that our job is going to be, continue to be highly respected, still going to be highly needed. We just may be, working or coming about things a little bit differently. Um, I don't know if we would have that proverbial seat at the table. It seems like, and one of the things I'm famous for saying, if the seat's not there, bring your own. So I think that we as a profession, being the largest member of the healthcare profession, there's something wrong that we don't have a voice in how our profession is practiced. So we need to be able to be in that C-suite and and advocate for what it is that we need in order to provide health care, either in the acute care setting. I agree with you, it's probably going to be more community based. Because I think payers are finally, as they are now, beginning to realize, hey, it is important that we invest in preventive health care. We save a lot of money on the end. When you look at insurance companies, for senior citizens, getting them involved in the Silver Sneaker program, or maintaining their health, or calling them in and saying, yeah, we want you to come in and get an annual physical, or whatever, or we'll send a home health nurse out to your home to do a home evaluation. Are there things there that that may subject you to a potential injury? Like, are there throw rugs or things that you could easily trip over now that you're older, as opposed to when you were younger and were able to do that? What about the temperature of your hot water heater? Have you turned it down because your skin's gotten thinner? And yeah, you may have gotten just used to how hot your hot water is, but sometimes with thin skin you're going to get a burn, and so or let's look in your cabinet and see, one, are your essentials lower so that you don't have to climb up on a step stool,
Yep.
or if you are supposed to be on a special diet, and I'm looking in your cabinet and I see let's say if you got diabetes and I look and I see you got all these carbs and things like that, maybe it's time to do some other education. And it's not like as though we're invading your home or whatever, but it's to try to get you to understand
Yep.
this is going to help you live longer. And I think using that perspective of long, healthy life as opposed to a long chronic illness life is going to get the attention of the public to want to get that buy-in. And of course, being nurses in the most trusted profession, that's going to help with that, or help that go a very, very long way.
I agree.
So that's where I see things in, say, 10 years from now.
Yeah.
And also, hopefully we'll see more nursing research that will, again, continue to, create these evidence-based practice that, that just makes things that much more smoother and easier as well.
Yes. Yes, absolutely. I definitely think that there's this world where the combination of wearable devices, right? The Fitbits of the world, and the rings that people are wearing, and that combined with our smart technologies, and that combined with virtual nursing and telehealth types of options, and more of these nurse practitioner and PA led clinics that are drivable to the patient, more accessibility, is that if we can really focus on like what you said about allowing that technology to take away some of those menial tasks, some of the stuff that is not necessary for providing well-being, caring for the heart, caring for the spirit, right? Because that's what you need a person for. A person needs to care for the heart and the soul of a person.
Yes, absolutely.
And I think it's really sad when there's things that have kept people out of this profession, like Oasis charting. I can't tell you the number of times when I went into home health, if somebody said, my first question would be, are you Medicare? And they'd say yes. And I'm like, I can't do an Oasis start of care. I won't do it. And they'd say, oh, well, we'll have people help you, and we'll have someone in the office fill in the blanks for you. And I'd say, oh my gosh, the last thing I want to do is come home after having driven around and seen 8 start of cares, is to come home and do
what you did.
And do 2 hours of charting for each person. And because that is what keeps people out of these professions, and really good nurses who should be out there doing this type of community care. They don't want to do it because they're like, oh my gosh, I'm going to get this kicked back to me, and it's going to get kicked back, and you're going to want me to update this, you want me to update that, you change this, change that. And before I know it, I'm not even getting paid for that. So I definitely agree that, like, and I hope it's before 10 years. And I think it probably will be in some ways. A lot of the technology is moving so fast. But we've always been historically kind of slow at adopting technology.
True.
I think there's still places out that are doing paper charting.
There are. There literally are, and it's a shame, that they haven't gotten that way or caught up with us.
But I think that this has been such a fantastic conversation. You have clearly such a wealth of knowledge. I could probably talk to you for 2 days and learn so much from you.
Well, thank you.
So I'm just deeply grateful that you shared your time with me, Dr. Grant. And
well, thank you. It's my pleasure.
And so wonderful. You are welcome back on this podcast anytime you want.
We can make that happen, so not a problem.
Well, it's been fantastic, and I hope you have the best rest of your week possible. For those listening, it is Wednesday, but who knows when you listen to this, it's probably going to be a Thursday. But, but it is a happy hump day to us.
Yes, it is.
Well, Dr. Grant, do you have anything else you'd like to say to anyone before we go?
No, just thanks to everyone for listening in, and love to hear some of their thoughts and comments as well. It's nice to again see what's going on in other parts of the country and what people are thinking, and who knows, there may be some fantastic ideas out there that we can adopt that may actually be those forces of change too that we talked about.
Yep, absolutely. Well, if you're on Spotify, you can definitely go down and you can comment.
Okay.
And we like to check to see if anyone's making comments about an episode. And so feel free to do that. And thanks again for being here, Dr. Grant.
Okay. Thank you. Thanks for having me. Bye bye.